Hello, everyone. My task today is to discuss in 15 minutes a very interesting and expanding field, which is focused ultrasound for movement disorders. Do my best to do this in 15 minutes, but really there is a lot to say. These are my disclosures, nothing's really relevant to the talk I'm going to give. And I'm sure you're all familiar with the hype cycle of any technology, and this relates to anything, including focused ultrasound. We have seen a lot of interest from first publications, a lot of inflated expectations at some point, also disappointments. And now we're probably getting towards a more mature era where we are understanding more and more the pros and cons of this technology. As you know, there are many indications, some of which are already approved in the States. Many others are approved in other countries, and many more are to come in the near future. I don't have to tell you what focused ultrasound is because I'm sure the audience is familiar with it. This is the way it looks like. The patient is awake. This is Dr. Obeso assessing the patient in Madrid during the operation. And as you can tell from the pictures, there are thousands of ultrasound beams that are directed in different areas of the brain, in this case, to do a thermic ablation. This is done in the MRI, so we can actually see the lesion. We can monitor the temperature, and you see a cytotoxic edema in DW that then resolves. You also see edema in FLAIR, and lately you're left with a lesion. And now there are many publications looking at the outcome from a neuroimaging standpoint, and this one coming from our center, where we looked at the size of the effect and how the edema, for instance, can predict the results long term. We also know that the larger the lesion, the better the outcome, but also the higher the risk to see side effects. And this is why there are certain size that we don't want to get to in order to reduce the risks. So we're getting better and better at doing this. These are the pivotal studies done in essential tremor that you very familiar with, I'm sure. The first one was open label. The second one was sham controlled and clearly showed a dramatic improvement of the contralateral tremor scores, as I said already, in essential tremor patients. And we have now evidence that this effect is long lasting, 1 and 2 years after. But as you can tell from this individualized outcome, the effect is very variable. There are certain people that have an incredible response, some others that don't improve too much. And these ones are the ones that tend to have a recurrence of tremor over time. We also have the 3-year outcome coming from the same cohort, and same can be seen for this 3-year outcome. And as you can imagine, also disability tends to worsen over time, particularly when you group all these patients together because of the decay of benefit in some patients. We also have a better sense of the safety profile of this procedure, of this thalamotomy. The most common side effect is paresthesia, seen in 14% of these patients. But what I highlighted here is that in some cases, if you wait long enough, some problems tend to disappear. For instance, imbalance in dysarthria improved in one patient each, which is something we didn't expect to see at the beginning of this experience. We thought that whatever is left at the 1-year mark is going to be there forever. This is the longest available publication in terms of prospective study, which shows a very good result. This is from South Korea in terms of tremor score with no reoccurrence of tremor. And interestingly, this center doesn't even report side effects, which is a little different than what's been seen so far in other centers. And this is, for instance, when you pull all the data of safety in different cohorts, and you can see there is a 1% chance of having severe side effects. But really, most side effects are mild to moderate and include paresthesia, sometimes weakness or imbalance. When you pull all the 1-year data together, you have a meta-analysis like this that shows a figure of 15% for paresthesia and 10% for ataxia. So this is a surgical procedure. It's certainly not risk-free, but as you can see, it also has a very good effect in terms of tremor control. So since we're now getting better and better at targeting the VIM with focused ultrasound, we're getting more confidence, and therefore we can now do also bilateral procedure. This is coming from our center publication, a paper already submitted, These are the first 10 patients that received a staged bilateral procedure within 6 months from the first one, at least 6 months. It is a single blinded trial prospective, and people are assessed 2 hours and 1 month after assessment, after surgery. And as you can imagine, this produced an important improvement of contralateral and ipsilateral tremor scores, and therefore you have an improvement of the total tremor rating scales, and also the quality of life improves. There were mild adverse events in 7 patients. These people were also assessed with a gait analysis and tandem gait. We didn't really see dramatic changes of gait, which is good news, although in 2 patients there were falls and gait impairment were reported by the patients, and this are in 1 case. But overall, all patients were satisfied. Actually, the co-primary endpoint was answering the question, would you do it again? And all patients replied, yes, I will do the second procedure again. So this is an example of one of the 10 patients. You see on your left the patient before the first thalamotomy, which targeted the right hand. And as you can see, the right hand was treated well at the center of the screen, but the patient has some tremor, obviously, on the left side that eventually was treated more recently. And you see in the video on your right that the outcome was excellent also on your left side, on this left side, as you see from the video. Let's change disease. Same procedure, VIM thalamotomy with focus ultrasound in Parkinson's disease. This is a sham procedure, some sham control procedure. And as you can see, there is an improvement of tremor, which is expected. But a difference with essential tremor, you see that in Parkinson's disease, there is certainly a greater placebo response, which is always a problem when you do this research in Parkinson's disease. Nevertheless, studies like this granted FDA approval for tremor management in Parkinson's disease. There's a lot coming up, and for the sake of time, I won't say much. This is just a list of new indications that have been successfully treated with thalamotomies. And there is also new data in terms of cognitive safety, and also safe in very old patients. And we also know that this procedure is cost effective. But as I said already, we also reported some people with failed focus ultrasound or reoccurrence of the tremor at some point, and these people were rescued with DBS or with a second focus ultrasound on the same target. We published the first example of such situation. This is a Parkinson's disease patient with an excellent outcome 1 week after surgery, and the outcome was sustained for a few months, but then the tremor reoccurred, as you see in the second sets of videos, and then we repeated the focus ultrasound on the same target, left VIM, and the patient improved. However, the patient developed a little bit of mild hemiparesis. Let's change target, palidotomy. Palidotomy is, as you know, done in Parkinson's disease, and the first experience came from a Korean center where they treated 10 patients, but they were able to successfully do the procedure only in 8 of them. And this is because the pallidus is a more difficult target with respect to focus ultrasound, because it's a more lateral target. So it's more difficult to focus all these beams in a lateral target. And this is part of the problem. Another problem is that there was one case of an interesting side effect, which was unforeseeable until this point, which is thermal coagulation of distant targets that were perhaps along the way of these beams, particularly the thalamus and the hypothalamus, as you see in the picture. But in the 8 patients that were treated, authors reported a satisfactory improvement of the UPDRS of MED and also UPDRS-4, which measures dyskinesias and motor fluctuations. Similar results were reported in a more recent multi-center North American trial in 20 patients. And you see there the type of side effects. And more recently, Insightec sponsored sham control, randomized controlled trials, the PD0006 trial, which is now completed, and the company just filed pre-market approval application to the FDA. So we can possibly see that this is going to be another FDA approval for Parkinson's disease. Another target, subthalamus. This is coming from a single center in Spain. Unilateral subthalamotomy in people with Parkinson's disease, very asymmetric. Excellent outcome with respect to all the cardinal signs of Parkinson's disease on the contralateral subthalamus that is treated, as you can see from this video. And the same group just published the double-blind sham-controlled randomized control trial, confirming the same result against sham. There were 27 patients versus 13 that received sham. In one case, there was an aborted procedure because of anxiety that you see here indicated by this dot. But the vast majority of people had an improvement of the UPDRS at the 4-month mark, which is the primary endpoint. No side effects in the sham controls group. But if you look at the total sample of subjects, 4 and 12 months, you see that the concerning side effects of dyskinesias is still present, 7% at the 12-month mark, and these are all new on medication dyskinesias. But there are a number of other problems, weakness, speech impairment, balance impairment, and also weight gain that you see also in ST and DBS patients. So this is a video coming from the first publication of this group in Lancet Neurology. And you have an example of such dyskinesias in one example, in one patient. And in this patient, dyskinesias improved at the 6-month mark. And the authors argued that this is because the lesion is not just in the subthalamus, but involves also the pallidofugal tracts, so in the white matter above the subthalamus, which is the reason why some people are now arguing that you need to target the pallidothalamic tract to have an improvement of all signs of Parkinson's disease, including dyskinesias. And this is particularly the experience of one single center in Switzerland. They have published a number of papers. Unfortunately, they are not blinded. They are prospective, but the follow-up is around 1 year. But what I find interesting is that they could do bilateral procedure in 15 patients, and actually they did it in one session in 13 of them without doing a staged procedure. And so this sounds interesting. This is a very crowded area of the brain with many other bundles, but the safety profile is not very clear at this point because these authors haven't really published a lot of detailed information about the adverse events. Certainly the fact that you do this in the MRI suites give you additional tools in your hands like tractography, and this is something you can do on the individual base, like that you can see on your left. Obviously, this is for a thalamotomy. You want to be targeting the dentorubro-thalamic tract, but at the more general level, you can actually use this to infer the targeting, and you can make sure that you are away from important tracts like the pyramidal tracts, the middle lemniscus. And actually, when you compare the tractography-based targeting with the classic indirect targeting, you realize that the target with the former is more anterior, more medial, right there where the VIM is supposed to be. We are now also establishing efficacy and safety maps. We know where to go, but we also know where not to go. And in this respect, we're also working on something new. This is one of the first patients ever treated in Toronto. And as you can tell, the effect was quite bilateral, even though this man received a unilateral VIM procedure. And I'm sure this is something that has been seen in other centers as well. So we've been looking at the effect of unilateral thalamotomy on ipsilateral and midline tremor. And again, looking at these maps of efficacy, and we could actually detect where you want to be if you want to have a more widespread effect, which is not just contralateral. Of course, this needs to be replicated, but I found this is very interesting and another important thing of another important way to use the MRI. So in 2017, I published this review where I put together all the unknowns of MRI guided focus ultrasound back then. We are at a more mature stages, and we now have a better sense of all these unknowns, which I can say now are not unknowns anymore. There are still problems that need to be addressed. Some others have been addressed. One important aspect is that this procedure has been long seen as a non-surgical procedure by patients and some physicians, which raises some concerns. But the positive aspects of this is that because of what I call the MRI-guided focus ultrasound effect, we have seen an increased number of patients referred for surgery. So people are now more familiar about surgery for tremor, and this eventually increased the number of DBS patients, standard lesion thalamotomy, and also focus ultrasound thalamotomy in our populations. There are a number of new indications and applications of this technology, which we won't discuss for the sake of time. I just want to give you a glimpse of this with this recent publication, where this group from Madrid, again led by Professor Obeso, use a different type of focus ultrasound technology to open the blood-brain barrier And this has been done in people with dementia, in Parkinson's, opening the BBB at the parietal lobe. And interestingly, they also observed an acute effect on cognition. Obviously, this is something that needs to be replicated, but mirrors what's been done in other diseases like Alzheimer's disease. So this is something you already saw before. I think for MRI focused ultrasound lesioning, we are towards a more mature stage, while with lesioning surgery that you're going to hear in a second, we have doing this for decades and decades. So we are at the so-called plateau of productivity. But if you look at focus ultrasound for other technologies and other indications and applications, we are a different level of this hype cycle. And obviously with time, we'll get more and more familiar with the pros and cons of these other aspects of this very versatile and exciting technology. And with this, I want to thank you all for your attention and the many people working with us at Toronto Western, particularly Dr. Lozano and his neuroimaging team group. Thank you all, and I'm happy to take questions later on.